Welcome to the Explainer. Today, we're going to tackle something that probably walks up to your pharmacy counter every single day: plantar warts. You see them all the time, right? It's a frequent presentation, a common complaint, and honestly, it's a real chance for us to shine with our counseling. So let's get a quick practical refresher. All right, so here's our game plan. We're going to walk through this just like a real patient consultation, from the initial, "What is this thing on my foot?" all the way to knowing when it's time to say, "You need to see a doctor." Okay, first things first, the foundation. What exactly are plantar warts? Getting a quick handle on the basic science here is so important because it's the why behind everything we're about to tell our patients. So, here's the absolute bottom line. These are not just tough spots of skin. They are caused by a virus. And that one little fact, it explains, well, pretty much everything. It's why they can spread, why they sometimes come back, and why our treatments are all about getting the body's own immune system fired up. Okay, check this out. The incubation period can be up to 20 months. I mean, that's almost 2 years. This is a huge counseling point because when a patient says, "I have no idea where I got this," you can tell them that's actually really common and explain why. And here's a number you'll want to have in your back pocket, especially when you're talking to parents. Up to 78% of warts in young kids just go away on their own within 2 years. Now, it is important to mention that this rate really drops off after age 12, but it's great for managing expectations. All right, section 2, assessment. This is where we put on our detective hats. It's so important to make sure we're actually dealing with a plantar wart and not a corn or a callus, because the treatment is completely different. Okay, this chart is basically your cheat sheet. There are 2 big clues. First, the pinch test. Warts tend to hurt more when you squeeze them from the side, while calluses hurt more when you press straight down. But the real smoking gun? It's those little black dots you see when you pare down the top layer. Those are thrombosed capillaries, and they're a dead giveaway for a wart. Now, before we even glance at the OTC aisle, we have to run through our red flags. These are the absolute exclusions for self-care. If your patient has diabetes, any kind of circulation issue, or is immunocompromised, it's an immediate referral. No exceptions. This is our safety net. Okay, on to the counseling. This is where we really empower the patient, right? We're not just selling a product, we're giving them a strategy. That means talking about prevention and making sure they know how to prep the area to get the best possible results from the treatment. This stuff seems like common sense, but it's so important to actually say it out loud. The virus loves warm, wet places like gym showers and pool decks. So counseling on things like wearing flip-flops in the locker room or always covering an existing wart, that's how we stop the cycle of transmission. And this right here, this can be the difference between success and failure. You've got to walk your patients through these 5 steps. First, soften the skin. Then, gently file down that top layer. This is key so the medicine can actually get in. Then protect the healthy skin around it, apply the treatment right on the wart, and then cover it up. Simple, but crucial. Okay, let's get to the main event, the treatment plan. This is what patients are coming to us for. So what are the evidence-backed first-line options they can grab right off the shelf? This is probably the most important concept to get across to patients. None of these over-the-counter treatments are antiviral. They don't directly kill the virus. What they do is act as irritants. They're basically sending up a flare to get the body's own immune system to notice the wart and come in and do the cleanup work. So, this is the classic trade-off, isn't it? You've got your 2 main players. Salicylic acid. It's cheap, it's effective, but man, it requires patience and daily application. Then you have cryotherapy. Less frequent application, but it costs more and can be a bit more painful. This table is the perfect tool to start that shared decision-making conversation with your patient. All right, and we're not done yet. The follow-up. Our job does not end when they walk away from the counter. Setting clear expectations about how long this is going to take and what to look for is absolutely key for safety and for a good outcome. So this is a great timeline to have in your head. You can tell them, you should start to see some improvement in a week or 2,
But don't get discouraged. Full resolution can take up to 12 weeks. And you know what? Suggesting a quick check-in around the 4-week mark is a fantastic pro tip to see how they're doing. 12 weeks. Just remember that number. If a patient has been treating consistently for 3 months and it's still there, our job is done. It's time to refer. And to be super clear, these are the big signs that it's time to see a doctor. Obviously, if it's still there after 12 weeks. But also, if the wart is getting bigger or spreading, if the skin around it looks infected, red, painful, any pus, or if the treatment itself is just causing way too much pain. That's the signal to stop self-care.
And that really brings us to a final, pretty important question for us in our practice, right? We know some of these warts are just incredibly stubborn. So how do we, from that very first conversation, manage our patients' expectations to set them up for success and not for frustration?